I would like to thank the organizing committee of the AIOS for inviting me to be part of the program. Today, I'd like to share with you a case of a traumatic cataract that resulted from a blunt trauma involving a projectile. These are my financial disclosures. None of them are relevant to this talk. So the case is that of a 15-year-old male who presented to the emergency department 3 hours after an injury to his right eye. The mechanism of the injury was that he was standing close to his father, who was mowing the lawn. The blades of the lawnmower propelled a stone which struck him in the right eye. Examination revealed that the vision was hand motions barely. There was a large central epithelial defect. There was corneal edema. The anterior chamber was formed with dense hyphema. Iridodialysis was evident. The intraocular pressure was 16 by applanation, and no detail of the lens or retina was possible on examination. Ultrasonography was performed and revealed that the retina was flat. So in summary, we have a blunt trauma injury which has resulted in significant disruption of the anterior chamber, but there's no evidence of any rupture or penetration into the eye itself. The treatment was to use atropine and Tobradex eye drops. The patient was followed on an almost daily basis. By day 5, he had a 3 millimeter hyphema. The epithelial defect had resolved. The lens was noted to be white, and the intraocular pressure was 11. By day 17, a superior blood clot overlying the area of probable iridodialysis was noted, and the IOP was 17. By day 40, the hyphema had resolved. There was no blood clot. A white cataract was still evident. The IOP was 10, and ultrasonography revealed that the retina was flat. At 2 months, we were left with a white cataract. The IOP was 15. There was no inflammation evident, and ultrasonography continued to reveal that the retina was flat. The plan was for the patient to undergo cataract surgery during the new year after his school examinations. Examination prior to surgery revealed the following. He had a white cataract. Since this had formed fairly recently after his injury, the assumption was that there was a capsular rent, either anterior or posterior. There was evidence of fibrosis superiorly. Posterior synechia abounded. There was traumatic mydriasis with an atonic pupil and a suspected area of inferior zonular dialysis. The white cataract is our main concern, as there is some suspected capsular rent causing this. Initially, we start introducing vision blue into the eye, but quickly realize that this may be a mistake, as a suspected inferior zonular dialysis would allow the vision blue to go into the vitreous cavity and affect our visualization later in the case. So viscoelastic is used to blockade that area. Vision blue is then reintroduced to stain the capsule, and then viscoelastic is used to expel the vision blue from the anterior chamber. The viscoelastic is used to tamponade the anterior capsule and its and the contents of the capsule while we create our capsular rhexis. A lot of fibrosis on the surface of the anterior capsule makes this capsular rhexis somewhat difficult, but manageable if we go slowly and use the capsular rhexis forceps. Having created the capsular rhexis, we introduce our phaco tip and quickly remove the liquefied contents. We are always wary that there may be a capsular rent and vitreous present, but luckily this is not the case. We then remove the remaining cortex using our IA and confirm that there is no capsular rent present. Our next step will be to introduce the viscoelastic and the IOL into the bag. A 3-piece IOL is chosen prior to the case, as this would allow us the most flexibility, allowing us to not only place the lens into the bag, but also allow us the luxury of placing it into the sulcus or fixating it either to the sclera or iris if complications deemed that this was necessary. Having placed the lens into the bag, we now address the traumatic mydriasis using microforceps. The iris is pulled towards the center and any of the adhesions to the angle and anterior synechiae are lysed. As you can see, most of the mydriasis is inferior, and this is where we are doing our pulling. Once we've deemed that enough has been done in order to allow us to do a pupilloplasty, we then introduce our tenoproline on a curved needle and take a number of bites along the inferior 180 degrees. We then bring out the needle through the cornea As I said earlier, our goal here is to make the pupil smaller inferiorly, so we've cut the needle off. We now pull one end of the suture out through the main wound and then pull the second and the other end of the suture out in the same area, pulling the needle through that wound, and then we will tie inferiorly so that the iris is made smaller, the pupil is made smaller in this area. As you can see, we do this and then we repeat the process again in the lateral aspect of this eye in order to create a semi-round pupil. So having taken two purchases, we've now completed and tied and made a smaller pupil. At the conclusion of the case, we can see that we've addressed the patient's traumatic cataract and traumatic mydriasis and have obtained a very good result for him. In summary, this case demonstrates blunt injury in a pediatric aged individual. We know that blunt injury is more common in males and can occur in a ratio of 12:1 when compared to females. It is usually unilateral. In India, about 75% of the injuries occur in those of lower socioeconomic status, and 92% usually from the rural areas. In terms of the mechanism, wooden sticks, firecrackers, and bows and arrows are the most common causes of blunt eye trauma. And as this case demonstrates, it is possible to have secondary or delayed surgery if there's no prolonged inflammation or uncontrolled IOP or retinal detachment. Also, if the patient is outside of the amblyogenic age, meaning that he's older than 7 or 8 years of age, and in cases in which follow-up can be assured. Thank you for your kind attention.